Hello guys, good evening. Today we'll be having a discussion on thyroid cancer and its comparisons. We'll not be having a detailed discussion on various cancer. Rather, today we'll be having the comparison of common thyroid cancers. We'll also see its classification, thyroid cancer classification, and we'll see the flowchart for the management of common thyroid cancers. So, welcome to my channel. I'm Dr. Lalkrishna, final year surgery resident at Tata Hospital, and this session it will be helpful for MBBS graduates and also for NEET PG aspirants where there is a confusing scenario in case of a thyroid cancer. Also, it can be used as basics for nursing students, BMS, BHMS, and other specialties, other healthcare professionals. So without further delay, let's get started. So thyroid cancer, these can be classified as differentiated thyroid cancers or undifferentiated thyroid cancers and others. So in the differentiated thyroid cancers, we have papillary thyroid cancer. Then next is the follicular thyroid cancer and Hurdle cell thyroid cancer. These are the differentiated one. In the undifferentiated, we have the anaplastic thyroid cancer, and among others, we have medullary thyroid cancer and thyroid lymphoma, thyroid metastasis, and others. So this was all about the classification of thyroid cancer. Now we'll be seeing the comparison of most common thyroid cancers. So first we'll be starting with papillary thyroid cancer. So papillary thyroid cancer, these are the most common thyroid cancers, and these account for around 80%, 70 to 80% in the thyroid malignancies, and these are commonly seen in younger population, that is in 30 to 40 years of age, that is third to fourth decade, and these cancers are commonly associated with external radiation exposure. Now comparing it with to the other differentiated thyroid cancer, that is the follicular thyroid cancer. So this follicular thyroid cancer is seen in a slightly elder age, that is 5th to 6th decade, and these are commonly seen in patients where areas where there is iodine deficiency. So these are in the iodine deficient endemic zone. These are around 10 to 15%. Then comes the medullary thyroid cancer. These are also seen in the same age group as follicular, and these are special thyroid tumors arising from the C cells, that are the parafollicular cells of thyroid, which produce the calcitonin. So these are the special group of thyroid cancer which are very aggressive. Then comes the anaplastic thyroid cancer. In anaplastic thyroid cancer, it is seen among the more old people, that is the 7th to 8th decade, that is 70 to 80 years of age group, and these can be seen in differentiated thyroid cancers after long term, that is when they de-differentiate from the differentiated thyroid cancer. So these are the most common cancers. The papillary, follicular, and medullary and anaplastic are less common. Now coming to the clinical features and its comparison. So the first one, that is the papillary thyroid cancer. These will be presenting to us with a neck mass. Generally these are painless, and sometimes they can be showing the spread, that is the lymphatic spread, in the level 6, that is the pretracheal prelaryngeal lymph nodes, Delphian lymph nodes, and sometimes when spread more, that is the hematogenous spread, that can be through lungs, That is the most commonly spread site. Then in the follicular thyroid neoplasm, the clinical features is again neck mass. Generally it is painless and it is associated with long-standing multinodular goiter, multinodular goiter. And here the spread is more common in the through the hematogenous route than the lymphatic. So through hematogenous route, it spreads to the bone, that is the most common site, and here it is chances that it is highly vascular metastasis and it gives rise to pulsatile form of metastasis. So we have to remember that here the most common site is bone through the hematogenous route and it will be highly vascular and will be pulsatile. And these lesions are osteolytic lesions. And then less commonly is the lymphatic spread, again to the level 6 lymph node, which is seen in around 30% cases. Then coming to the medullary thyroid cancer, these also present as neck mass but are also associated with cervical lymph nodes. So here the chances of cervical lymphadenopathy is higher and these are more aggressive and infiltrative, so causing pain. So these are painful in nature. Also they will give rise to being aggressive, infiltrating. They will be giving rise to dyspnea when involving the respiratory passage. When involving the larynx, they will be giving rise to dysphonia, and when esophagus being involved, they will give rise to dysphagia. They will also be producing paraneoplastic syndrome through the various substances produced by them, giving rise to diarrhea and Cushing syndrome. Then coming to the anaplastic thyroid cancer. So these anaplastic thyroid cancer, they arise from generally long-standing neck masses, and here there will be history of rapid enlargement. So within few months, maybe 1 or 2 months, it will be growing very fast and will become painful again. So it is an aggressive tumor. Then there will be dyspnea, dysphonia and dysphagia. These are locally invasive, giving rise to ulcer and necrosis. Here we have to consider that these anaplastic tumor, the neck mass is like woody hard or stony hard. So these will be hard. Most of the cancers, their consistency is hard, but here in the anaplastic cancers, it is called as stony hard or woody hard. So these will be very hard. Now just coming to the management, the differences in management of these thyroid cancers. So the first one, that is the papillary thyroid cancer. So here we either go for a total or hemithyroidectomy. So we'll see the important aspect, that is when do we go for total thyroidectomy. So if there is distant mets, extrathyroidal extension, size is more than 4 centimeter, cervical lymph nodes are positive, histopathology, it is poorly differentiated, history of radiation and bilateral nodularity. So in all these cases, we go for a total thyroidectomy. And if these scenarios are not there, then we go for a hemithyroidectomy. So we can go for a hemithyroidectomy. Then comes the neck dissection. So here we go for a prophylactic central, either ipsilateral or bilateral neck dissection, and especially this is done for T3 and T4. So this prophylactic central ipsilateral bilateral neck dissection is done when the tumor size is more like is T3 and T4. Then if there is lymph node positive, then we go for a modified radical neck dissection type 3 or functional neck dissection. Along with that, we also use radioiodine therapy and TSH suppression for preventing recurrence. Then in follicular thyroid neoplasms, here we again go for total and hemithyroidectomy. We go for total in when the size is more than 4 centimeter, extrathyroidal extension, metastasis. So these 3 points are almost similar to papillary thyroid neoplasm. Apart from that, we go for total thyroidectomy if there is atypia, that is the histology is atypical, and if there is a family history of thyroid malignancy. So here in all these cases we go for a total thyroidectomy. In other cases we can go for a hemithyroidectomy. Also sometimes when considering that the lesion is benign, we can go for a hemithyroidectomy with surveillance. In case of benign, that is follicular adenoma, or if it is a variant of encapsulated follicular parathyroid papillary thyroid neoplasm. So in case of encapsulated follicular papillary thyroid carcinoma, we again go for a hemithyroidectomy with surveillance. So neck dissection, it is done if lymph nodes are positive and only the involved compartment, generally level 6, the central compartment is dissected. If lateral compartment are involved, we'll again go for that enable modified radical neck dissection type 3. Similarly, here we also use radioiodine therapy and TSH suppression. Now coming to the medullary carcinoma of thyroid, which are aggressive cancers. Here we have to go for a total thyroidectomy. We don't go for a hemithyroidectomy. So we have to note this. Along with that, we'll go for a bilateral prophylactic central neck dissection, and we'll go for a bilateral lateral neck dissection if there is lymph node positive or the primary tumor is more than 1.5 centimeter. So we'll go for a bilateral lateral neck dissection when the lymph node is positive or the primary is more than 1.5 centimeter. In case of recurrence or widespread metastasis, we again have the role of debulking so that there is no pressure symptom or invasive symptoms. In case of unresectable or recurrent mets, we may use radiotherapy in the form of external beam radiotherapy, EBRT. For liver metastasis, we use radiofrequency ablation or percutaneous ethanol injections, and targeted therapy, that are multikinase inhibitors and sunitinib. Then lastly, coming to the anaplastic neoplasms, these will be needing total thyroidectomy again because these are aggressive, and we'll go for central neck dissection, and along with that we'll go for a modified radical neck dissection depending on the invasiveness. Generally it is type 3, modified radical neck dissection type 3. In case of advanced tumor, we go for chemotherapy, that is doxorubicin, targeted therapy in the form of tyrosine kinase inhibitors like dabrafenib, and tumor debulking in the form of isthmusectomy or even total thyroidectomy as per need, and adjuvant radiotherapy. So this was about management of the anaplastic. So we can understand and see it in comparison. And lastly, just before going to the flowcharts, for thyroid lymphomas, surgery is rarely required, and the surgeon's role is mainly until the diagnosis, that is in the form of biopsy. Once it is biopsy proven, it can be managed by chemotherapy, that is the R-CHOP regimen, and sometimes, very rarely, we may need surgery when there are chances of failure of these line of drugs. So in short, the surgical role in management of thyroid lymphoma is quite less. Now coming to the flowchart for management of the differentiated thyroid cancers, that are the papillary, follicular and Hurdle cell cancer. So we'll go for history and physical examination, and along with that we'll go for quadruple assessment, which includes the ultrasound examination, the thyroid function test, and lastly the FNAC or biopsy as per need. And sometimes when it is an aggressive cancer, we may need the 3D imaging in the form of CT or MRI of the neck and chest. So thyroid nodule, we'll check for that, the palpable lymph node if there are any family history of thyroid cancers, any history of radiation. So this and the other history details and the examination detail, when we have found that it is thyroid cancer, in the diagnostic workup, as we have discussed, the quadruple assessment, which includes the first is the history, then the thyroid function test, the ultrasound and the FNAC. Sometimes we can go for molecular testing when there is diagnostic dilemma, and CT scan for invasiveness and chest extension, retrosternal goiter, vocal cord evaluation for documenting and preventing further problems after surgery. Then when the thyroid cancer is less than 1 centimeter and there's no extension and no metastasis to lymph nodes, then we can directly go for thyroid lobectomy. That is, we can go for thyroid hemithyroidectomy. When it is more than 1 centimeter and less than 4 centimeter, we can go for total thyroidectomy or thyroid lobectomy again. And there is no evidence of metastasis here again. And in case when the size is more than 4 centimeter or gross thyroid extension, we go for a total thyroidectomy with central lymph node dissection. For any biopsy proven lymph node spread, lateral lymph node spread, we again go for modified radical neck dissection type 3. And after all the surgery, we will be having the risk stratification for further management, that is American Thyroid Association risk stratification. So it is called low risk depending on the low thyroglobulin levels when there are less than 1, diagnostic radioiodine scanning, and generally here we don't need ablation, that is radioiodine ablation. We'll go for T4 replacement since we are removing total thyroid, and we'll be monitoring by thyroglobulin TG levels and ultrasound. So here we'll be just replacing thyroid hormones and we'll be monitoring. In case of ATA intermediate risk, depending on the thyroglobulin levels when it is 1 to 10, and diagnostic radioiodine scanning, here we go for low dose radioiodine ablation. Generally it is recommended, and T4 replacement as per need, surveillance with TG and ultrasound, and radioiodine scanning. In case of ATA risk, when thyroglobulins are more than 10, diagnostic radioiodine scanning, radioiodine ablation is strongly recommended at a high dose, T4 replacement as per need, and surveillance with TG, ultrasound and radioiodine scanning. So this is the management protocol which is used for thyroid well differentiated cancers. Then coming to medullary thyroid cancers. So here again we'll go for history, which includes the family history, the examination, and by the quadruple assessment, which includes ultrasound, FNAC and thyroid function test. When we come to a diagnosis that it is MTC, that is medullary thyroid cancers, then we will be having a serum calcitonin level, serum CEA and neck ultrasound. When the calcitonin is less than 500 and there are no neck lymph node positive, then here we go for a total thyroidectomy with central neck dissection, and depending on the calcitonin levels, we'll be going for ipsilateral lateral neck dissection when it is more than 20 and bilateral lateral neck dissection when it is more than 200. So this is a special scenario. Then when there is lymph node positive, then we'll go for thyroidectomy, total thyroidectomy, central neck dissection with lateral neck dissection, and we'll go for a bilateral neck dissection when the calcitonin is more than 200. So we have to understand that if the neck node is positive, we'll go for involved lateral neck dissection, and if the calcitonin is more than 200, we'll go for bilateral neck dissection. In case when the calcitonin is more than 500, we'll evaluate for distant spread, that is METS, through the CT neck and chest triple phase contrast of liver, bone scintigraphy and axial MRI. And here we'll be going depending on the involvement. Either we can go for total thyroidectomy, central neck dissection and bilateral lateral neck dissection, and radiotherapy as per need. If there is any residual lesion, extensive nodal disease and extrathyroidal extension, and if the other thing is not possible, then we go for a thyroidectomy followed by treating the regional disease and systemic therapy versus clinical trial. So these are generally done when the disease has spread to distant sites. Now for familial, we go for a DNA analysis if we are considering familial positivity. So if it is red positive, we evaluate for pheochromocytoma again and hyperparathyroidism. So if it is positive, then pheochromocytoma, the adrenal is removed first, adrenalectomy is done first, and then for parathyroids, hyperparathyroidism, parathyroidectomy is done along with thyroidectomy. So these surgery are done in stepwise fashion. First adrenalectomy, then thyroidectomy along with parathyroidectomy. So this is the flowchart for management of medullary thyroid cancer. So here we have to understand that in short, we have to go for an aggressive surgery in medullary thyroid cancer. That is, we go for a total thyroidectomy along with central neck dissection and ipsilateral or bilateral lateral neck dissection. So this was all about the flowchart for thyroid cancer comparison. Hope it was helpful and will be helpful for management and understanding and exams, that is both theory, practical and entrance exams in MBBS and postgraduate levels. So thank you for watching. Please like, share and subscribe and never give up, because great things take time, and keep studying, keep growing. And thank you for watching. See you soon in next video. Thank you.